All right, we're live.
All right. Good morning. This is the Senate Health and Welfare Committee. It is February 4th, and we're here joined this morning to talk about the budget adjustment and to meet folks from Department of Vermont Health Access. And thank you, Commissioner Gustafson, for being here, and you've brought a crew with you. So I'll turn it over to you. And we do have your information on our webpage, so we'll look at that. And just an FYI, two of our members, or at least one of our members right now, Senator Terenzini, is on telephone, and another member, Senator Hardy, is having internet difficulties, so she will join us either by phone or video as soon as things work out for her. So thank you all for being here. I think you know everyone on the committee. Well,
yeah. Hi.
ahead.
Good morning, everyone. Corey Gustafson, the Commissioner of the Department of Vermont Health Access. We're here to talk about budget adjustment. Nellie, when we get going on it, I'm assuming you're going to pull up the budget adjustment document that we submitted. But before I get to that, I do want to just do introductions of, well, first, with me today, Lisa Schilling is our financial director. And she is, in case there's extreme detail that we get into related to the budget adjustment, she'll be able to assist us. And also, I wanted the members of the committee to meet our two deputy commissioners, Addie Strumolo and Sandy Hoffman. And if they could just sort of talk, we've done this a couple times, introduce themselves and maybe a little bit of background in their areas of responsibility.
Sure, I'm happy to jump in. This is Addie Strumolo, Deputy Commissioner at DVA. In my role, I oversee eligibility and enrollment, so the process for Vermonters coming into the programs that we run. In addition, I work with the policy group, the oversight and monitoring group, plan management and appeals. Thank you.
And I'm Sandy Hoffman, the other Deputy Commissioner, and I am a licensed clinician and oversee the clinical aspects of DVA.
Nice to meet you. I'm not sure that you've been in our committee before, or at least this session. Thank you.
Okay, Nellie, do you want to pull up the budget adjustment document that's on the website? And I'll just walk through it. I will say, as that's happening, the budget adjustment is relatively, it's not complicated. I'd say there is a up in the gross in program and administration, but that's to DVA's budget, but it isn't. That's the one that I don't think you guys want this one. I think what you want is Nellie, the narrative. I'm sorry. I didn't realize with the policy committees, I think the narrative works a lot better. Anyway, what point I wanted to make is that there's a lot of net neutral, so AHS to DVA adjustments that are part of our budget adjustment proposal, and that is what I will describe first. Of course, a big piece of our budget in the overall is to note that we have the 6.2% FMAP increase as part of our ongoing response to COVID. So if we go to number one, we'll start on the administration side. For anybody that might be new to our budget, I'm not sure, Senator Hooker, how much experience you have with our budget, but maybe like every committee or every department, we have our administration costs, things we do to run our program, and the program is the spend on goods and services for our members. I'm gonna skip ahead of explaining too much about Medicaid and DVA at this time, because that can be a long conversation, and just jump into our administration and the two items that fall into that spectrum. So the first is money movement. It is not anything other than spending authority or actually in this case, it's the backfilling of money that has already been appropriated and delivered from the previous calendar year. Our agreements with the ACO are on calendar year basis. And in the calendar year 2020, last year in the budget adjustment, actually, the legislature approved money going to the ACO for delivery system reform investments. Some of those dollars were expended, but some weren't. We were in a conversation with the ACO to get greater and greater detail on what those DSRs would be paying for. Once we achieved that, we were more satisfied with what they had to present and to describe the DSR expenditures. DEVA did pay the ACO for those amounts that were appropriated last year. But the amounts that were held over and not expended were still at AHS. And so this budget adjustment, AHS carried over from last fiscal year, from FY20 to its own budget for 21. We're in 21 now. DEVA expended those dollars earlier in this fiscal year, but in calendar year 2020. And now AHS has to pay the amount, well, has to make our budget return it to whole. And essentially this is just tracking money. It's not new money. I know this could be a sensitive.
Corey, just one really quick, when you use the acronym DSR, you're talking about delivery system reform.
Yeah, investments related to delivery system reform. Yeah, trying to create a more aligned and coordinated system of care.
Senator Lance, could I ask a question, please?
Yes.
Commissioner, you said that there was money expended through the ACO, but some wasn't. Do you have information on what it was expended on and why the rest?
We do. We can get you what those DSRs went towards. That was actually why there was a delay of the expenditures, because we wanted to be 100% sure that we had an understanding and we're comfortable with what those DSRs expenditures were. So yeah, we will take that note and share with the committee
Okay, thank you.
the outline of what the DSRs for 2020 went towards. It was, in many cases, it was a continuation of what's been done before, but I think we have a better description of from the ACO of what they've been working on to promote care coordination, for example.
Thank you.
The second is a backfill of unallowable CRF funds. If you've had any budget adjustment testimony in your committee at all, you've heard that CRF indirect administrative expenses were assumed to be okay, then they weren't. New administration, that may change again, but in our BAA right now, as we know it, AHS had to transfer DEVA money for these unallowable CRF administrative expenses. Those are the only two items as part of our administration BAA. So Nellie, can we go to the next page unless there are questions? So we are now into our program spend. As I said, this is goods and services for Medicaid beneficiaries. There are two big items on this. It's number 3 and number 4. They offset each other to you know, in state funds essentially make us kind of level fund, or I'd say not needing really more money as it pertains to our caseload and utilization changes that are going up. Our caseloads are going up. So number 3, I won't read this, but I'll just say to you, there are a couple of reasons, of course, our caseloads are going up. The economic environment, we would assume that there are more people economically income eligible for the Medicaid program. We would also note that the 6.2 bump in federal matching dollars comes with the requirement of continuous coverage, health coverage. So right now, Medicaid or DEVA, the Enrollment and Eligibility Unit, have suspended redeterminations. It's something we have to do on an annual basis to make sure that anyone getting Medicaid health coverage continues to be eligible for the program. this continuous coverage requirement for the 6.2 bump makes it so that we aren't doing redeterminations, and therefore we aren't people aren't coming off the program right now. So it's really just, there's an indoor and no exit to the program. And so naturally we are seeing growth in our enrollments. I will say it continues to be less than some of the anticipation early on in the pandemic. There were very large predictions of how many people might be coming into the program, but it's been more steady than anything else. And just for context, I'll say on a normal, and there is no normal, of course, but on average, when we are doing redeterminations on a regular basis, which we had been up until the pandemic, there would be about 1,500 people a month that would churn off of Medicaid, and so not having that is obviously affecting our caseloads. Maybe go ahead.
I think you answered my question there, but the time frame for a redetermination and what it's based on, I think that might help folks.
Yeah, it's 1 year, and it is on all items related to Medicaid eligibility. It isn't certain things, if anything. So we process those. If you remember years ago, there was a time when those weren't happening, and that was a significant issue. As of 2017, we were able to execute on redeterminations, and we had become pretty proficient at it, even though our system required a lot of requires a lot of process related effort. But stopping these, I'll just take this opportunity to say to this committee, stopping redeterminations means that there are a backlog of redeterminations that need to happen. And so, given the process related, which means very manual process that is, remains to be part of our system, it means that when the pandemic ends and the FMAP bump ends and redeterminations are required of us again, that will happen, we are going to have to work through that backlog. What's going to be a real question, and we have already started discussing this with the federal government, is whether or not, or the timeline, I should not say whether or not, the timeline of when we will have to get back to no backlog. That will be a definite issue for us to make sure the federal government is aware. Given our system, it's going to take a while, and so that just is part of it.
There shouldn't be any question that CRF or additional federal dollars would support the administration of that. I mean, it's going to be, I would think, since it's an increase.
Yeah, and thank you for sort of raising the dollars issue. Actually, what I'm talking about is it's just the workload.
Well, that's what I'm talking about, sort of the workload, administrative workload to get it all done. It's very,
it's work that you can't just throw resources at in a short fashion. And so, right, if there were dollars and we had access to Medicaid beneficiary specialists, if there were a lot of those out there out of work, we would hire them all and use CRF dollars and solve that problem. But it is, given the process base, the manual processes involved, it is the kind of work that you would really have to, in a methodical way, build resources around, and then you'd have, once you got through the process, what do you do with all those people? So it's a good point, and we're not afraid to look at any way, shape, or form to get through that issue. But I think the timeline with the federal government is the first and foremost on our list in terms of making sure that we don't fall out of compliance with our federal partners, because Medicaid is a state and federal partnership, and the big part of that federal partnership is the dollars they expend to pay for Vermonters' healthcare who are in this program. So, I haven't quite gotten to utilization.
I do have one question, Commissioner. So are you saying that the 6.2 bump has helped monetarily, that you're not worried so much about the money, but it's the processes coming after the pandemic that will be the problem. And I think Senator Lyons, suggested that the CRF funds should be helping to cover that process, and to extend the times that are, do you have any idea when we'll have information on that?
Well, first of all, yeah, you got it exactly. The FMAP bump is of significant value to the state. You all know that. You're going to see it in any of your budget, I think, related to Medicaid. DVA is not the only entity within state government that expends Medicaid funds. But you're right. It's really and understandably, the requirement that no one comes off of Medicaid is just creating this backlog. And we at DVA know that when the pandemic ends, that's probably when our fund really starts. And we'll do everything we can to mitigate the issues. We won't know. Well, I shouldn't say that. I would welcome the federal government to come out and say you'll have as much time as you need to meet your backlogs. But I imagine it's going to be more of a negotiation than that. And I would assume that the federal government and OMB, this is the other part. It isn't just CMS, right? It's other parts of the federal government that have an impact on how CMS does its work and what it requires its states to do. So the Office of Budget and Management will come in and say, hey, you got to get this done in 6 months. And then that's when I guess the conversation might get a little bit tougher for us. But I don't know right now what that conversation will look like. Right now, we are raising it through our national organizations to make sure they know. I think with I know Senator Lyons, the NCSL probably might be another place to raise that. And I don't have a strong connection to that group, but I know you legislators do. That might be a good item to put on their radar as well. We're definitely through the Medicaid director, the National Association of Medicaid Directors, we're raising that issue, and probably the NGA as well will hear about it from us. But it's going to be an issue, and I'll make one more tie-in for you all here, is that this really does point to why the upgrades and the evolution of our integrated eligibility and enrollment system is so critical to us. No one planned for the pandemic, but we have to react, and our systems being as either as old as they are or as not as well connected as we would like them to be, makes us more vulnerable probably than other states. So a little plug there for understanding the value of the integrated eligibility program, not just for DVA, it's really for all of AHS, and of course for the people that are in our programs in the state. So
Thank you.
I am gonna just say one more thing about caseload and utilization, and I have a short thing, so we're okay on time. So don't hesitate to ask questions. Utilization changes is another thing that right now, utilization on a PMPM level isn't as high as we would anticipate. So for the number of people that have come on in caseload, the utilization would probably require a normal not normal, but like our what we've seen for utilization of late would make this much higher of an ask or a need, I would say, because we aren't really asking for these dollars. But it just seems like utilization is down, understandably, probably because, like we said, people aren't coming, we aren't removing people from the program. They may have other insurances or might not need it. The other thing is when people come onto the program for eligibility or due to income eligibility, they're in that space that they can be on and off. And usually that's a healthier population. We do have populations that are categorically eligible. They don't rotate, they don't churn on and off. And so their level of care and needs are more stable. Anyway, the point being, we believe that the other thing I didn't mention is, we're in a pandemic where people are a little bit concerned of going out. So probably there's a little bit of deferred care. And so that will come up. I want to put that in that seed into the conversation for when you start thinking about the budget for next year, that we anticipate. Right now we're calculating that caseload will go the other way and utilization will go the other way. So they will actually end up being kind of similar, but for different reasons. So just a outline of where we're at, and then an outline, a little foreshadowing for the budget for next year as well. Number 4 on this list, moving on to the ACO reconciliation for plan year 19. The ACO, based on our contract, we had an agreed upon price. The fee for service portion of the ACO utilization tracking, and it's not the ACO itself, it's the network of providers and the care delivered to Vermonters through the fee for service model, exceeded the agreed upon price, and so due to the contract obligations that go both ways, there's a risk corridor above and below the agreed upon price. Because the fee for service utilization tracked above, the ACO repaid us this amount, the $6.6 million, and we are able to put that against our caseload and utilization changes in this current fiscal year. And so it meets one of the goals, I think, of that health reform stream of work as it pertains to the ACO program, which is to smooth the ups and downs of the payer and the providers. I'll just take this second to mention, in a normal world, we would be asking the legislature for the $8.1 million, and instead we're balancing it out with the reconciliation from a previous year. And so that is the smoothing we're looking for, so that it isn't either we have, providers are underfunded, or payers are under, behind, in the red in terms of how much money is going out the door to providers. It creates more of a shared accountability, and hence the name, I would say, Accountable Care Organization. So unless there's questions on that, I will move to the next page, Nellie. This is one of the more regular items we have on our BAA. It's an updating of our Medicaid buy-in. So the federal government allows states to use Medicaid dollars to buy in to Medicare on behalf of our dually eligible beneficiaries. So we buy Medicare coverage, and the state or the federal government bills us for that buy-in, and the adjustments are made regularly. And this is the updated price of covering these qualified groups. You can see them listed there. Everybody knows their nicknames that have been at this for a while. They've heard Quimby and Slimby before. But this is just an item that we basically have every budget adjustment to adjust for. Number 6, this one is a little more difficult to explain. In 26, we have, how far to go back? 1115 waiver of the state right now is on a pathway to reducing our ability to use investment dollars to pay for mental health care in institutes of mental disease, IMDs. So we lost the authority to use investment dollars in our 1115 in 2016, and we've been put on a pathway to reducing in a called a phase down what is spent as investments on IMDs. So since that time, 2016, we've recognized that we have to move in that direction, but we've also pursued 2 other waivers and achieved those, this serious mental illness waiver and a substance use disorder waiver, that have allowed us to move spend related to IMD care into those waivers and offset. And so we've accomplished phase down as far as we needed to go now. And by having these waivers, it hasn't hit us that's why you see the 0 and the 0 there. It doesn't hit us in any way, shape, or form budget-wise, but it's good for the committee to understand that this phase down is happening, and that those two waivers that were achieved in the last 2 years, one was 2 years ago, the other was just last year, are very valuable to us as we accomplish this phase down that we are obligated to complete. I believe it is by 2024. Someone else might have that specific number, but I think that's in the ballpark that we have to have phase down for. We will say to the committee that we are engaged in building our 1115 proposal, because our current 1115, that updated 1115 that happened, the renewal that happened in 2016, is now in process. This current updated 1115 waiver expires at the end of this calendar year. We're engaged with a technical assistance vendor who is helping us put together a proposal to go into a negotiation with CMS around mid-year. And just say, I'm highlighting that for you because that's happening, and you will hear about this, I think, more during the session. But what you should know in this case is one of the items on our wish list is to get to recover the lost IMD investment authority in one way, shape, or form. It'll be a pretty significant state dollar impact by 2024 if we don't achieve some success in getting the federal government to participate in our mental health expenditures.
I'm not going to ask the question now, but there are a lot of questions embedded in what you just said. And when we have DMH and you back in, we'll try to get at some of this going forward. But
sure,
yeah, big.
Next page, Nellie. I think we have one more issue to cover. This is another one that's like not easy to explain and probably harder to understand, but it relates to Coronavirus Relief Fund. It relates to two elements of federal funding. The Medicare Clawback, which is pharmacy coverage for, I believe it's the duals as well. And then the CHIP program. We basically, it's another good deal for the state that we're engaged in, but the FMAP money changed the calculation on our general fund needs and in 2021. And so we have some state dollars that we propose to carry forward into the next year, because inevitably we're going to need this money when that FMAP bump goes away. It looks different in the budget, and I just did the budget, so it's a little bit confusing even for me, and to go back and forth between adjustment and then the actual FY22 budget. But this is, it's again related to the 6.2 bump, and creates some state dollars that we think we'll need in the next fiscal year. So we're proposing to carry it forward. And that's the last item on our budget adjustment, Senator.
Thank you for that. Nolan Langwell said that this wouldn't be a concerning BAA report from DVA, and he's right.
Yeah.
Yeah.
I mean, fortunately,
Yes.
the CRF dollars have been huge. The FMAP bump, incredibly important. The CRF dollars, because of all the dollars we've been able to distribute to the provider community to make sure that access to care is preserved. That's a Medicaid responsibility. But AHS jumped up and didn't waste any time in making sure that as the healthcare system was closed down, dollars were getting out the door. But all of that work and all that federal participation, the state, acting quickly, the legislature appropriating dollars, all those things, I think have made it so that the impact of and you see it in the revenues, of course, the impact of the pandemic could have been a lot worse. And like I said, we could be in here. You've had this, the veterans on this committee, I can see two right now that I know have had that moment where Medicaid has had to come in and say, we need $30 million to make sure that we have enough money for providers and cover the care that's not needed. So we're not in that position. We're all very thankful for that.
Commissioner, thank you so much for taking the time to be with us. And we're going forward. I know next week we'll be working with JFO as long as they're available. We'll be looking at some of the guidance and potential use of new federal dollars. And then obviously we're going to be looking at the budget as that plays out and from the policy perspective. So I know we'll see you again.
Yeah, that's right.
Yep.
Absolutely.
But
Thanks for the time.
thank you very much and take care.
Bye now.
So committee, that I think that's helpful. That's kind of because it wasn't a heavy lift for us, that's a good way to get kind of begin to look at DEVA a little bit. And when we come back to the budget, we'll get even more information going forward. Also, it might be a good idea just to go back and review Nolan's slide deck on Healthcare 101. He's got the information there about Medicaid, FMAP, global commitment, and so on. So, all right. So now we're going to move back. It's really some testimony that we would like to take on. It's actually going to be a request for S42. I'm just checking a note from, yeah, okay, thank you, Nellie. S42, not S42, I apologize, for the flexibility bill. And so this might be something we want to consider putting into the flexibility bill. We have a couple of folks coming in today to talk about remote signing for advanced care directives. And Olivia, are you going to start? And then good morning. And then Cindy Brazesi will be in a little bit later. So what do we have something from you? Hold on. I thought we did. Do we have a document from you? No. Okay.
No, Chair, nothing.
That's
in writing.
okay. So remind us what we did last time and then what you're asking for. That'd be great.
Absolutely.
And before that, I'm just going to introduce the committee members: Senator Cheryl Hooker from Rutland, Senator Ann Cummings from Washington County, and Senator Josh Terenzini from Rutland County. And then Senator Hardy is still having technical difficulties getting on, but she represents Addison County, and I'm Senator Lyons representing Chittenden County.
All right. Good morning, everyone. Thank you so much for having me. My name is Olivia Graffio Cohen. I'm a staff attorney at Vermont Legal Aid, and I work in our medical legal partnership project. So we are speaking today about possibly extending the provisions that were passed in H950 last spring related to the execution of advanced directives, advanced healthcare directives. And at that time, we had expressed some concern because the statute for advanced directives typically requires that a witness and the principal, the person creating the directive, be physically in the same location. And so we had asked, given social distancing requirements or recommendations, many people did not feel comfortable with that, were high risk and wanted to execute a document, but didn't feel like they had the ability to do so safely. And specifically, that statute also prohibits close family members from being a witness. And for many people, the only people in their bubble, the only people they were having contact with were people who could not help them execute that document. So the bill created, there was sort of a protective mechanism for people who had sort of done their best for some window of time in the spring from February to June of 2020. If you had a remote witness as long as you knew each other and certain name and contact information was included in the document, those documents were considered valid for a limited period of time. And then there were specific provisions that had slightly heightened requirements that would allow you to remotely execute a document that would be valid indefinitely, same as any other advance directive that you might be executing according to the original statute. And just, I can briefly overview, it required that the principal and witness know each other, that you're using either video or phone communication. The witness had to attest that the principal seemed to understand the document and be acting freely. Those are the statutory requirements. And then the document needed to include the witness's name, contact information, and the relationship that they had to the principal. And then there was also a provision that confirmed that people doing a heightened explaining function for folks who are in a nursing home, a hospital, or other facility, that they would normally need to have a third party, an ombudsman, I believe an attorney, a clergy member, explain the nature of an advance directive to them, so that, you know, it's an extra protection against maybe undue influence, or just given the nature of why they might be creating the document. The bill also confirmed that that explaining function could take place remotely. So the bill, those provisions were allowed until June 30th of 2021. I think at the time when we were discussing this last spring, that felt very far out, and we had hoped that things would be a little calmer than they are now. So after speaking, some of the stakeholders who were corresponding about H950, we kind of all touched base. That included the Long-Term Care Ombudsman Project, the Vermont Ethics Network, Vermont Legal Aid, Disability Rights Vermont, and a few other folks. And it seemed like there was pretty strong consensus for extending these remote execution provisions, just recognizing that our case numbers are still high. We're still seeing, you know, restrictions both generally and within care facilities. We now, unfortunately, have some highly contagious strains that are, you know, up and coming. And it seems likely that public health officials are going to be recommending at least some distancing procedures just for public health for the foreseeable future, even with the vaccine rollout. So we want to make sure that people can continue to execute these documents while following those recommendations. From what I've heard, the procedures are working well. In the course of my work, I haven't heard any complaints or barriers to executing directives since H950 passed, which, you know, I hope is a good sign, not hearing anything negative. So it seems to me to be a good idea to continue making these procedures available, making sure that these documents are more accessible while people have kind of healthcare planning on their minds. So that's kind of my brief overview. I'm happy to answer any questions either about the prior bill or going forward.
So thank you for that. That was a good reminder of what we did in H960 and the guardrails that are in there. Very briefly, can you remind the committee about what an advance directive actually is and does? Just real quick.
Absolutely. So an advance directive, it allows someone, while they have capacity, you know, and they're sort of planning ahead, to articulate what kind of treatment they might want in a situation where they are not able to articulate their wants and needs. So if they're later incapacitated, it basically gives guidance to healthcare professionals and to a person that they have named to help give guidance to healthcare professionals. So it names someone who they want to kind of take charge and make decisions on their behalf. And then it articulates, ideally, what they would want, or at least give some kind of indication that would help that person. And it can include a whole variety of things, depending on what someone puts in, but it basically it's just a guidance document that hospital or healthcare providers can use.
Thank you. Senator Hooker.
Thank you, Senator Lyons. Thank you, Olivia. I'm curious to know if you have a preference. We've heard from others when we're discussing these extensions that some would prefer a date certain for this, for us to put into this bill, as opposed to 3 months after the pandemic, the order is lifted or whatever. Do you have a preference for that?
Yeah, so we had discussed this originally also. I think a date certain in this particular context is helpful because we want to make sure that someone in the future, because these documents are valid indefinitely, we want to make sure that someone looking back can clearly identify, oh, this was executed remotely using these procedures within this very clear time frame in the statute. That seems easier than saying, okay, the document was executed on, March 13th, 2020. Was that before or after a state of emergency ended? Can we consider this valid? Can we use this? So having the date certain allows for better cross-referencing in the future.
Did you put your hand back up, Senator?
Oh, gee,
Are you?
I didn't realize that you had lowered it. Or someone had lowered it.
I just lower it after you
Oh,
start.
I don't know. I'm
Okay.
lowering it now.
Okay. All right, Olivia, any other questions for Olivia? All right,
Very much.
and I just want to say good morning to Senator Hardy. Welcome. And Senator Terenzini is now not on the phone anymore, which is good. Cindy Bruzzese is here, and she's going to also testify on the request for the extension of advanced directives. You heard at least one of the questions that were asked, and Olivia did a very good job of going through what we did in H960. So the extent to which how much of that goes back in the bill, I think, is something that both you and our Ledge Council will be helping us with. So why don't you go ahead with your testimony, introduce yourself. And we have new members of the committee who may not have met you before. So we have Senator Cheryl Hooker, Senator Ann Cummings, you do know, Senator Josh Terenzini, Senator Ruth Hardy, and we know each other. So Cindy, why don't you go right ahead?
Thanks so much for, I apologize for my delay. And thanks so much for having us here to talk about this today. So I am Cindy Bruzzese. I'm the Executive Director and Clinical Ethicist at the Vermont Ethics Network. And I also work part-time as a clinical ethicist at the University of Vermont Medical Center. For those of you who may not know who VEN is, who this ethics organization is, we are a statewide not-for-profit, and I think we're most well known for our work on advanced directives and medical decision-making and supporting Vermonters and healthcare providers in Vermont in helping patients to both complete these documents and to exercise their sort of right to self-determination by making sure people know what their wishes are and what their priorities are around their healthcare if and when the time arises where they can't make decisions for themselves. So that's the bulk of the work that my organization, I think, is most well known for, and the context in which I've come to this committee over the years. I also direct a statewide task force on palliative care and pain management. So I also do a fair amount of work with healthcare providers who work in hospice and palliative care and who are caring for people at the end of life to try to make sure we're doing the best we can to make sure people who are experiencing life-limiting illness have access to the best care possible throughout their disease and as they approach end of life. So that's another piece of work that I do. So that's a little bit about the Ethics Network for the newer members who may not be as familiar with our organization and what we do. In terms of the testimony today, yes, last year we were here also talking about this topic about how do we ensure that people who want to complete advanced directives are able to do so at a time when social distancing and limitations on visitation and their restrictions are required due to a national and certainly a statewide but global pandemic, where we have obligations to protect the public health. And so prior, and I'm sure Olivia covered this, prior to you making some changes last year, witnessing of these documents needed to be done in the physical presence of the person who was signing the document. That's the way it's always been. And obviously that physical presence requirement was causing some problems for people, as particularly people who are older and more at risk of having a potentially bad outcome if they were to contract COVID. And so Act 107 passed, and we created this structure to allow for there to be remote witnessing. And I think where we are now is at that time, we were, I think, very hopeful that back when we passed Act 107, we thought that pushing it out to June of 2021 seemed like way beyond what we were probably really going to need, but we wanted to make sure we could still do it. And so it's interesting to be here we are. And now we're saying, wow, June 2021 is not that far away. And we're nowhere near going to be going back to business as usual with people being in close proximity to one another. And so I think the increase in the community prevalence that we're seeing right now of cases of coronavirus, as well as concerns around some new and potentially more virulent strains that may be coming, are going to require some ongoing vigilance when it comes to mitigating strategies to prevent the spread of infection and to reduce, I think, severity of outcomes. So even if we were to a point going to be able to even have some relaxation on some of those things, I think we're still going to be in a place where we're going to need to allow for people not to have to be in close proximity. I will say that COVID-19 has prompted quite a renewed interest in the idea of doing advanced care planning. Our call volume at the Ethics Network was, we responded to, and just so you know, our organization is myself as a full-time ethicist and director and one part-time staff person who manages kind of the phones. We responded to over 900 calls and emails since coronavirus has come into being, with people asking for questions around wanting to complete documents or to update existing documents and wanting to make some modifications to the information they've provided in the event that COVID were to be a disease that they were to contract. So this is definitely on the minds of Vermonters and the desire to be able to document their wishes has become really important, particularly because someone can be okay and then be very not okay very quickly if they were to contract COVID, and their ability to communicate their preferences, that could pass so quickly that we aren't able to get that information. So I think there's been a strong desire. So we really feel like there's a need to ensure that people are able to do this and they're able to do it safely. And we think that they're going to need to be able to have this ability to do it remotely, probably beyond what we were thinking was a far off date of June of 2021. And so we are in support, along with legal aid, of extending the date to 1 year out to June 30th of 2022.
Okay. Questions, committee? Okay, so Jen, Ruth, go ahead, Senator Hardy.
Thank you, Cindy. This might be a question for Jen. Did our draft that we went over yesterday include this? I didn't think so. Okay.
No, it's a different bill.
It's a different bill.
Yeah, it's different.
I mean, last year, right, last year this was H 950, became Act 107. It's just a different act. So you certainly can put things in, but because you hadn't talked about it yet, it was not in what you looked at.
So
Okay,
I think Senator Hardy is asking my question, so go ahead.
Well, I was just wondering if we could put it in that bill, if that would make sense, into the one that Jen is drafting. But if we did, would it, I think the other ones are March 31st, 2021 or 2022. And would it be problematic to have two different dates? Didn't you just ask for June 30th? I'm sorry.
I did.
She did. Just let me say this, before you came on, the comment was that this was something that we were considering to add into the flexibility bill. So that's one. And then the question about having different dates, it is, we can make our own decision about what to do. Jen, you can help us with that. Remind us what the predominant extension is in the current flexibility bill. Not what we decided yesterday, really.
As currently drafted, it is 3 months after the end of the state of emergency. So it is not a date certain. You did hear testimony from a number of witnesses asking you to make it a date certain. Others may want the flexibility for it to move, but I don't see any problem with having this one pegged to this part pegged to a date certain, even if it's a different date certain than the one for the other flexibility provisions.
Okay, that's
You can make
helpful.
them all different if you want.
That would be fun. Okay, so June 2022 is your thinking on this one?
Yeah, I was thinking June 30th. And part of that has to do with the fact that having clear dates, and I think I caught just a little bit of Olivia's testimony towards the very end. It's really important in the sort of the medical context, because as an ethicist, I often am called to help interpret advanced directive documents when there's a decision that needs to be made. And I think these documents are often difficult to tease out anyway in terms of people's goals and wishes, because they're somewhat nuanced frequently. But I think knowing that we are looking like, is this valid legal document? Being able to answer that question right out of the gate is so much easier if we know that if it was completed during this time by this process and the date is within that window, we don't have to worry about whether this is valid. Having to go back and try to remember when was the state of emergency lifted, what was the date of that, and now do these documents, that becomes really hard to operationalize in real time at the bedside when maybe time is of the essence in terms of decision making. So a date certain is most helpful in that medical context for the purposes of this request.
Thank you. That's very helpful. Other questions for Cindy? Senator Hooker.
Thank you. And thank you, Cindy. Can you just tell us how many members there are in the Ethics Network?
Oh, we're not a membership organization, so we're a freestanding not-for-profit. We have 12 board members who basically are from all across the state, and some actually from New Hampshire, Dartmouth. We do a lot of work with Dartmouth, and our Vermonters go to Dartmouth a lot, so we have someone from their hospital on our ethics committee as well. And so we don't have a membership organization. We are freestanding, sort of by choice, actually.
And you've had a lot of interest in these planning documents that we're talking about here since the pandemic has occurred.
Oh yeah, the organization's been around since the early 80s. And so we've been doing this kind of work for the state of Vermont for a number of decades now. And I've seen definitely in my tenure, it's just coming up on 13 years now, that the influx of questions was noticeable once the pandemic hit. We also do oversee the contract for the Vermont Advanced Directive Registry, which is something it's in statute that Vermont requires that we have in the state for people to put their documents in this registry. And so much of our work is during this pandemic has been on facilitating updates to documents in the registry as well. So we oversee that contract as well. So we're working quite frequently with all of these documents and with Vermonters trying to make these changes.
Thank you.
Other questions? All right. So thank you for this. And I mean, it certainly seems like something that should be extended, and there's a lot of reassurance, I think, for folks who are making these decisions that during a pandemic and then shortly after, they'll be able to do this remotely. And your experience with this, just one quick question, the sort of the security provisions that are in there, the protections that are in there for the patient, or the person who's developing the advanced directive, have you seen that those have been effective and are working? Do you have a comfort level with what you've requested, or are there any changes that would need to be made?
Hold on. I think that, I mean, I don't have any data, you know what I mean? Because I only
Yes.
get questions
No,
I
it's
get. But I will say that when we get calls from people who are trying to complete and update documents, when they're a little stressed, oftentimes people are anxious to get these documents done, and they're worried about how they're going to do it when they find out they have to have a witness. They're like, well, I have to get a witness. How am I going to get a witness? And then when we say you can do it remotely, all you need to do is and outline the process, there's relief on the other end, right? That this can be done. I have I work with a group, we have this work group called Advanced Care Planning Champions, or people that are doing this work within their communities across the state and trying to be kind of the go-to point locally. And they are feeling like this is working very well. They like the idea, and they like that we've given them a bit of a script. You know, they have to say, like, by being my remote witness, you're attesting to the fact that I, the principal, seem to understand the nature and effect of the advanced directive and was free from duress or undue influence at the time of signing. So we've told people in our instructions, like, this is the process and this is what you need to do. And now that they know it, they're doing it, and then they're documenting it accordingly, saying either verbal witness per COVID on the signature line and including all the relevant information, or video witness per COVID if they're doing it via Zoom or Teams or whatever, platform they're using. And so far I've not heard, I did query my advanced care planning champion group to say, how's it going? Because they're the boots on the ground people doing it with Vermonters in different parts of the state. And so far they said it's going well, where people are relieved that there's a way to do this, that we can, and they can get these documents completed. It kind of gives them some peace of mind if and when something should happen.
Thank you. Okay, unless there are other questions, we have another topic that we've added on to the agenda after just today. So another witness who wanted to testify relative to the flexibility bill. So unless there are questions, are there other questions for Olivia or Cindy? We're good. Thank you. Thank you for bringing this to our attention, and we'll work assiduously to get it into the bill. All right. And it's
Thank you
good to
very
see
much, everyone.
Take care.
Stay safe.
So now it was brought to our attention that during the pandemic, there were, and I think this may all, I don't know, but it may relate to the cyber issue that we had recently, but mostly related to the pandemic, some internet data access problems. And so Beth Anderson is here from Vital, and she's going to present what the issue is. And then this is also relates to our flexibility bill. And it may be something we'd like to include in the flexibility bill. So Beth, this is, I think, the first time you've been in the committee this year.
It is.
And
Hello.
I'm just going to go around and introduce folks for simplicity's sake today. But Senator Hooker from Rutland, Senator Cummings from Washington County, Senator Terenzini from Rutland County, Senator Ruth Hardy from Addison County, and I know you, I'm Senator Lyons, so welcome. And why don't you, we don't have anything in writing from you, but are you going to be sending something to Nellie?
Yes, we can do that.
Okay, terrific.
Yes.
So we'll listen to what you have to say and what the suggestion and request might be.
Thank you so much. If it's all right, I'm going to take just a minute to give background on why we're here. So we, as a result of the pandemic, as Vital, have been working very closely with the Vermont.
I don't mean to interrupt, but
Please
not
do.
everyone knows what Vital is. So just briefly.
Step back. Great.
Yep.
Thank you. So we operate the Vermont Health Information Exchange, which basically puts us in a position where we work with healthcare organizations across the state. And that includes hospitals, independent practices, FQHCs, some of the designated agencies, to collect patient data. And then we kind of enhance that data through matching up records and standardizing terminology that's used, and then make it available back to providers to help them inform patient care and improve care. And so it can be used at point of care. A provider could access our provider portal and not only see the information they have about a patient, but could also find their test results. Had they been in the emergency room the night before or seen a specialist a few weeks ago, I'd be able to see their results. We also work with some of the programs more around quality improvement or care reform. So directly with OneCare, with the Blue State for Vermont for Health. I'm sorry, the Blue State, the Blueprint for Health program, their chronic care initiative to help them inform some of their programs and improve the care that's provided for patients. And so in that collection of data, we've been very closely working with the Department of Health since, as you can imagine, last April, to help them collect data on the COVID pandemic. So it started initially with making data available for the epidemiology team to do their case investigations for patients who tested positive. Traditionally, they would have to call providers for that data, and just the volume of calls and providers being focused on such other more important things, it helped them get the data they needed without having to call the providers and take their time. We then started working with them as testing became more prevalent. We worked with them to connect to the new labs and locations that were doing testing. So we provide them with daily reporting that informs them about the testing that's happening across the state, the positives and negatives, and then also provide them additional data, which they use for capacity planning, resource management, as well as to do some of the federal reporting that's required to HHS by the hospitals in this state. As things have progressed from there, we've been fortunate to be able to work with them to help support their need to get data on immunizations. And as you know better than I do, the number of immunization sites is growing across the state. And so far, we've connected to 56 new locations for them to get immunization data. We're working with about 71 additional locations to get that data for them. So we get that data submitted to us on a daily basis from these sites, or at least a daily basis from these sites, and we provide that data that we get from the immunizations to the Department of Health. Some providers do go directly to the Department of Health with their data and goes directly into the immunization registry. So we don't get that information back into the Health Information Exchange, or the VHI. So what?
Let me ask this question. So you mean that if it goes directly to Department of Health, there's no reciprocal entry into your system?
Yes. So that leaves us with incomplete patient records.
Oh dear. Okay.
Right. So Department of Health is unable. So let me make sure I get this right. 18 VSA 1129D allows the Department of Health to share registry information with, it's very specifically with healthcare provider networks, but not with the Health Information Exchange. And they want to share the data back to us because we want to be able to provide providers with a complete picture, particularly with the scale and scope of this immunization program, to have the providers have this data accessible in one place where we can do some reporting for them on their patient population so they can manage their at-risk populations, or can manage just their patients, just when they have patients coming in, knowing who's at kind of what level of immunization. So the request really is to expand the language in 18 VSA 1129D to right now it says the department may provide confidential registry information to healthcare provider networks serving Vermont patients. We would just ask, and we worked with VDH to come up with this language to change that to be, the department may provide confidential registry information to healthcare provider networks or health information exchanges serving Vermont patients, which would then allow them to share the data back to the VHI to have a complete patient record.
Okay, questions about the request, and I did ask, or I did have that language sent to Jen, so what we can have a discussion about it as we're moving forward on the bill. But first, questions for Beth about the request. Go ahead, Senator.
I don't know if we'll get testimony from VDH, but are they in support of this? And this would still maintain patient confidentiality and comply with HIPAA, I'm assuming.
Yes. Yes, we have very strict security over the data that we have in place. We follow HIPAA, and the consent policy, the state consent policy, would be applied to all of this data as well. So if a patient had opted out of sharing, it would not be shared. Well, let me be clear. Yeah, we share our data with the Department of Health. It would not be shared with providers.
Okay. And what specifically is the data? Is it data about just positives and negatives, or does it also include additional patient data or demographic data?
It's the immunization record. So it would have demographics, so we could match it to the patient's record in the health information exchange. So it would have name, address, things like that. So we could match, and then it would just say, I don't know all of the specifics, but it would say when they had the vaccination, which version of the vaccination it was, so they could make sure they're getting the right second dose, things like that. But it's not test results or anything. We're really just talking about the immunization record at this point.
Immunization. And would it include demographic data like age, gender, race, and things like that, so we could determine that who's getting vaccinated?
Yeah, so that's a really interesting question. Usually it does, but what's nice is if it doesn't, we tend to have that information on patients because we have other records for them. And so a good example of where it's really valuable to have it in the VHI is with our work with the epidemiology team earlier in the pandemic. They were finding, and I'm sorry, I don't remember the exact numbers offhand, but the scale of what I'll tell you is about right. They were trying to put race and ethnicity to patients that were testing positive. When they were doing that through the manual case investigation, they were, I think, about 13 or 18% successful in filling that out. When they started using our data, it brought them up to like the 60, 70% level that they could get that information. So it does help actually inform some of their work too, in a lot of cases.
That's great. Okay, thank you.
All right, yes, good. So, yeah, so we did ask, we put into our act, one of our acts last year, the collection of data based on race and ethnicity, among other things. And so it's nice to know that your system is helping with that. Your record keeping is helping with that. Jen, I have a question for you, but first let me ask this. So Beth, are you asking to only have vaccine data, reciprocity with Department of Health?
That is the immediate need, yes. And so if we can get that
And
changed,
so,
that'll be.
but I guess my question is, and this will go to Jen, that if we're changing underlying statute, is that also a request so that this is ongoing? I'm not clear on whether there's a pandemic related request. No, I didn't.
No, it's right. Where they're looking at changing the language would be in the statute on the immunization registry.
Okay.
That's just an ongoing registry. So this would add the health information exchange there. So it's not time limited, and it's not restricted just to COVID vaccination information.
Okay, that was the question. All right, that's helpful. Other questions, folks? Wow. So this is good. We'll put this. I think, why don't we say thank you to Beth. Thank you for your testimony. And I don't think there are any other questions.
Well, just
Senator Hooker.
thank you. So this would be a separate bill. It wouldn't be necessarily included with the extensions, or could it be?
You can put it in. I mean, your bill is going to have whatever in it you want.
Okay.
So if you, and you know, I mean, I think that the idea is to move this piece of legislation quickly if this piece feels like something that is time sensitive, you may also want to put it in that same bill.
I can see the relationship certainly, but if it's something that's changing the underlying statute, I just wondered whether it would have to be in something else, but as long as it can be
No,
in.
actually, the advanced directive one also changes because it was codified last year, it was put in statute last year. So it's not just amending the act, but it is amending the dates in statute. So you can have any combination of session law and statute that you need to accomplish your purposes.
Thank you.
Good question. Okay,
Can I ask one question of the witness about language?
please.
So, hi, I'm Jen. I'm the attorney here. So I think in the language, or at least the way you described it, and I think what I've seen from Laura as well, it's talking about sort of health information exchanges as a general term, as opposed to elsewhere in the statute when we're referring to the kind of singular Vital run Vermont Health Information Exchange. Do you think it would be problematic to use Vermont Health Information Exchange as that specific one?
I have no issue with that. I worked with David Englander on this language, so if it's okay, I'd like to just check with him to see if there was a reason he thought bigger, but to your point, we are the state designated exchange. There is not another one, so I think it should be fine.
Okay, to me, it seems, particularly given the protections that we know are around the vital data, that it might make sense to be more specific. I also think it might make sense to make it an and, not an or, that they can provide information to the healthcare provider networks and to the exchange, and not one or the other. So those would be my recommendations around language.
Great.
Yeah, that's great. I actually, when I saw the language when it was sent to me this morning, and I had the same question, because I was thinking if you have an IT system in a hospital or in a clinic, you don't want all of those separate entities requesting the Department of Health to send data along every time there's a vaccine report. So,
makes sense.
Okay. Well, so you'll get back to Jen with David Englander's comment.
I'll follow up immediately after this. Yeah.
Okay. Any other questions for Jen or Beth? So I think, unless I hear differently from the committee, this seems like something that could be included in the bill. It won't have a date associated with it. It'll just go in. It makes a lot of sense to me. And there's one other thing I wanted to say about Vital, and that is when I had an appointment with my primary care in the Chittenden County area after the cyber attack, and everything was being done by paper, handwritten. One of the comments that she made was that the data was available on Vital, and thank heavens, because she could do a read only for her patients. So it demonstrates that some people think, oh, you don't need the backup system. But the reality is that the backup system is more than that. And it does extend across the state for other patients. So I just wanted to say thank you for that and express my support of the work that's going on.
Thank you for sharing that. The team was really proud to be able to help provide that information at that time. So thank you for sharing.
Thanks. Okay, committee, how are we doing? Jen, are you there? I think Beth, we're all set with your request, and we'll wait to hear back from you with the response from Department of Health.
Perfect. Thank you all.
Yeah, thank you. So Jen, we've got just a few minutes before we take a break. Can you just in a 5 or 10 minute period, can you maybe share with us what we're doing as a result of today in our flexibility bill, and you'll help us structure what we're doing, and then maybe we should after we have some further testimony, when we come back to this again around 11 o'clock, we'll have a longer time for conversation and going through the bill. But just those two things, I think, and then we'll take a break.
Sure. So I've actually been making some changes to it while you've been discussing. So I will have a new version to send to Nellie. After yesterday, I also just put in some sort of notes around the pieces that that OPR said weren't necessary anymore, so that we can look at what those are. And I pulled out the section 8, the DFR rulemaking piece, to make sure it was reflecting the most current version. But what you've talked about today is first around advanced directives and allowing those provisions for remote witnessing of advanced directives and remote explaining for when somebody's being admitted to or is a patient or resident of a hospital or long-term care facility, pushing those dates out from June 30th, 2021 to June 30th, 2022. And that is something that I put in the statutes last year. So usually time limited things we don't necessarily put in the statute books and the green books, but because these advanced directives would continue to be valid on an ongoing after the pandemic is over, after the time period is over, I thought it made sense to put it in the statute so that attorneys, courts, whoever needed to find it, to see if they were valid, could find it. So that's one piece, is the advanced directives and moving that remote witnessing provision out a year. And the second, the piece that you just heard about around the immunization registry, would allow the health department to share confidential immunization registry information with the Vermont Health Information Exchange, which is what Vital runs for the state. Because currently the health department is not permitted to share that information in that manner.
Okay, questions for Jen? So, yes,
One
Senator?
quick thing. In your current draft that you're sending to Nellie, does it include the date certain of March 31st, or is that something you still need direction from us on, or?
That is something I still need direction from you on. So you had not talked about that. I mean, you haven't really had a chance to have a committee discussion on this since you heard the testimony. So I'm trying to flag things, those few sections that OPR specifically said, we don't need this, and then add these new provisions for you to look at. But once you have made a decision on date, then I'll go through and do that for the next draft.
Okay, thanks.
Yeah, so we need to go through it first before, well, we could let Jen make all our decisions, and that'd take a lot of burden off our shoulders.
No,
No, I agree.
not how it works.
Yeah, so we don't have Nellie. Let me ask a quick question of Nellie before we take a break. Nellie, we asked to have the insurance folks in. When are they coming in? Do we have them?
That's tomorrow.
Oh yeah, today's Thursday. Okay, so they'll be in, and maybe we can frame up some discussion on the insurance request for audio only. And we'll be connecting with the House on that.
Yes, the House is working on language.
That's good.
As we speak.
We like that. Teamwork. Okay. Thank you all. Let's take a break. If you don't mind coming back at 10:40. I know it says 10:45, but let's say 10:40, and then we'll be ready to go. Nellie, you can put the screen up, and so we'll be back in a bit. How we doing?
Getting there.
All right.
There's a lot of snow on Church Street.
Yeah, is there? They haven't cleared it yet?
Yeah.
Wow. Well, we had 8 inches and it looked like we had more than a lot of places. I was surprised. Burlington had 6, I think. Oh. So Senator Hardy or Senator Cummings, are you? Yeah, good. All right. So we can probably get started because I think our witnesses are here. I don't see Deanna. She's here. Good. And John Gorton is here. Good. Terrific. So why don't we pull ourselves together? And you know, we're very fortunate to have both of you here today as part of Mental Health Advocacy Day. Ordinarily in the State House, we'd probably have a room full of folks and be able to have a conversation. So at least we have you here, and we're pleased that you are. So why don't we start? I'll let you organize yourselves. I think, John, you were going to go first, and members of the committee with you today are Senator Cheryl Hooker from Rutland, Senator Ann Cummings from Washington County, Senator Josh Terenzini from Rutland County, and Senator Ruth Hardy from Addison County, who will appear as we're moving along. And then I'm Senator Ginny Lyons of Chittenden County, and welcome to you both. John, why don't you introduce yourself for the record, and then we'll listen to your testimony. And you have something for us. Thank you.
Yes, I emailed to Nellie yesterday, kind of right at the edge of the, a little bit short of the 24-hour timeline, but I did email her a document that has my testimony in it. So
terrific, thank you.
Should be available.
We'll listen as you present.
All right. Off the record, in the Enosburg Falls area, I'm known as Kathy Stebbins' husband. And Senator Lyons, for you, I know you officiated at our niece Emily and Wilder's wedding a few years ago. And Senator Hooker, my wife, according to my wife, you were together at UVM along with Margaret Ryder, who lives down in, she looked at the list and said, oh, I know those. Okay. But for the record,
thank you for that. That was such a fun wedding.
That was a beautiful spot. Yeah, we have a great time. We still, have fond memories, and connections with all the Stebbins family and everything have been very difficult with the pandemic, but we used to have a kind of all the cousins would have a gathering.
Yeah.
We haven't been able to do that since the pandemic, but we're hopeful to do that again, where all the cousins.
It will happen again, and I'm so thrilled when I see Emily and Wilder. But Senator Cummings, you have a question. You're muted, Senator.
Probably knows unmuting me for this. I just wanted to know if it counted that my son-in-law is from Enosburg, and I drove through there last week.
Oh, it does. It does.
Okay, I'm part of the family now.
If he's from Enosburg, he probably knows my wife, because the Stebbins, the Stebbins family is they have a pretty big footprint in the Enosburg area.
He's a Rob toy.
John, you can tell Kathy that Margaret and I are still really good friends. And as a matter of fact, I'll be Zooming with her tomorrow night after our Pro Tem event.
Oh, all right. Super.
Oh, that's tonight.
So
tonight. Thank you, Senator Lyons. I don't know what day it is either.
No, we're all twisted with this. So.
Yes.
John, sorry to interrupt. The floor is yours.
All right. So for the record, I'm Grant John Gorton. I go by John, which is a handy distinction when you want to dump an unwanted caller on the phone. I'm a retired U.S. Navy nuclear submarine officer. I'm a retired Department of Defense contractor doing Navy ship design. And I'm a semi-retired farmer. You never really retire from farming. We no longer milk cows, but I operate a diversified beef, cash crop, and custom fieldwork operation in partnership with two of my sons.
Go ahead, Senator Cummings is.
Oh, I just wanted to know which nuclear submarine. I took part in the christening and commissioning of the USS Montpelier.
Oh, yes, I'm earlier days than that. I was serving back in I graduated from the academy in 71 and served on active duty until 1980, and then served in the reserves from 1980 to like mid 1990s. So yeah, I was kind of before the Montpelier. Yeah, before that time.
Can I ask you this? That you didn't happen to run into George Hayden, who was on the first nuclear submarine?
No, I was probably after him. I served actively on submarines from 1972 until 1980.
Yeah, he was right before you. He's a cousin of mine, a little bit older, but he did that.
So I am a certified lay servant in the United Methodist Church, and along with about 20 other volunteers, I'm kind of the cat herder. We run the Sheldon Methodist Church food shelf. We serve about 200 families, 600 people, and distribute about 20,000 pounds of food a month right now because of the pandemic. I'm active in the Franklin Grand Isle County Community Partnership. I serve on the executive leadership team. Active with the Franklin Grand Isle Hunger Council, the Franklin County Food Shelf Alliance, the Franklin County Building Bright Futures Council, and the Farm to Early Childhood Coalition. I've been active in the ACEs working group here in Franklin County, and I had attended several of the child and family trauma working group sessions that are still being held. They're being held by Zoom now, that come out of Waterbury. But I'm here today to testify about my family's now 12-year struggle dealing with a daughter-in-law experiencing serious mental health issues. In the fall of 2008, she did a semester of study abroad in Amsterdam, and as near as we can determine, she suffered some type of traumatic experience which triggered her decline into a mental health abyss. The last 12 years have been a roller coaster of times when we hoped that she was on the verge of recovery and about to pull out of the abyss, only to have her suffer another psychotic breakdown and fall back down. Over the 12 years, there have been dozens of calls to 911 with police intervention, dozens of visits to the emergency room, outpatient work by NCSS, Northwest Counseling and Support Services in St. Albans, and the Howard Center, inpatient stays at just about every psychiatric care facility readily available, including UVM Medical Center, Rutland Regional Medical Center, Central Vermont Medical Center, Brattleboro Retreat multiple times, Albany Regional Medical Center in Albany, New York, Four Winds Retreat, which is in Saratoga Springs, New York, Spring Lake Ranch, which is in Brandon, Vermont, and Bayview, which is in St. Albans. Our son steadfastly refused to give up on his wife, and my wife and I had supported him, dealing with whatever we had to deal with for 8 years, attempting to get her into recovery. Then they had a baby girl. That changed things significantly. For about 2 years, things were a little bit calmer, but still always walking on eggshells and always on the edge. Starting about 2 years ago, she became increasingly unpredictable with more frequent and more volatile psychotic episodes. It became clearer and clearer to my wife, myself, and our son that the child could not continue to be exposed to the toxic and traumatic environment created by her mother's mental health issues. DCF became involved, and we had several different safety plans where my wife and I taking on increasing childcare roles. Our son lives about 1.5 miles up the road from our farm, and our farmhouse became the safe haven for our granddaughter if our son was attempting to deal with his wife in a mental health crisis. A year ago, the first of 3 serious incidents occurred. Our daughter-in-law trapped my wife and I with the granddaughter in a bedroom upstairs here in the farmhouse. She was out in the hallway threatening us with a knife. We didn't have a phone with us, but she was on the phone to 911, and I could tell by the way she was shouting and screaming and acting and behaving that the police would realize that they needed to respond, and they did. with a NCSS mental health crisis counselor and my son also talking to her on the phone, we were able to diffuse the situation with no one being injured. She was taken to inpatient. Criminal charges were filed, and she was taken to inpatient. I believe that time it was to Brattleboro Retreat. But she was only there for a few days, and she was released into our son's recognizance, with supervised contact between the mother and daughter being required by either myself, my son, my wife, or sometime shortly thereafter, her mother, who lives in Colorado, flew to Vermont to be with us to try to help with the situation. But then in June, there was a second serious incident. She came into the farmhouse and assaulted both my wife and her own mother, knocking them down, smashing furniture. Once again, criminal charges were filed, and she again went inpatient. I believe this time it was when she went to UVM Medical Center. But once again, she was only inpatient for a few days, and then she was released. At this point, the court recognized that releasing her to the recognizance of either our son or her mother was not a practical option. And so she was released to the recognizance of Voices Against Violence and housed in St. Albans. The court also recognized that she could no longer be allowed to live in our son's residence with the child anywhere around. And at that point, her only contact with mother and daughter was supervised contact by All About Kids, which is a family support organization in St. Albans. The final straw incident occurred in late October. My wife was a few minutes late arriving to All About Kids for a supervised visit. She was told that our daughter-in-law had become very angry and left. Only our daughter-in-law hadn't left. She came running around the side of the building, coming up to the car where the granddaughter, was sitting in a car seat behind my wife. My wife rolled up the windows and locked the doors. She stood at the side of the car, literally pounding on the car and shouting and screaming obscenities and through the window at her daughter. She then left and ran back around the other side of the building. So my wife realized that she needed to leave. As she backed out of All About Kids onto Main Street, our daughter-in-law got in her car, pulled out of the other driveway, and intentionally rammed into the side of my wife's car, the driver's side of our car, disabling our car. She then fled the scene with her car. Once again, criminal charges were filed. Later that day, she was picked up by the police and remanded to Chittenden County Correctional Center without bail. A couple of weeks, 10 days or so later, in court, the criminal charges from all three of these incidents were dropped, but she was remanded to what we understood to be a 90-day mandatory inpatient at Central Vermont Medical Center in the psychiatric ward. Even that took a bit of a hiccup. At first, the mental health people, the Department of Mental Health said, no, we aren't going to accept that. And they had to have a second hearing a couple of days later, what they call an involuntary hearing, at which the judge said, yes, she is going there, no questions asked. So she went to Central Vermont Medical Center. Based on discussions with the Department of Children and Families, after that incident, our son filed for separation and obtained RFA protection for his daughter, with DCF in control of any contact between mother and daughter. Our daughter-in-law was released from Central Vermont Medical Center just after New Year's. She didn't do the 90 days that we thought. We're not sure exactly who is responsible for her. She was initially housed in a hotel in St. Albans, but because of behavior issues, she has gone to Colchester, and she's now in Burlington. There's a typo in my thing. DCF has continued to hold out the carrot that if she would get herself seriously into recovery, they would initiate supervised visitation. As of this moment, she's had no contact with her daughter since the incident in October. We had some hope a week or so ago. She participated in the intervention team meeting. And based on that, DCF set up a supervised Zoom video visitation, which is scheduled for tomorrow. DCF has not heard from her since that intervention team meeting, so we don't have a lot of hope that that visitation will even actually occur. While we'd like to be optimistic, but we don't think so. We are concerned that she is being exploited to support her drug habit. And in the near future, she will wind up either across breakers with the law and back in jail. She will wind up back in the ER, or even worse, she will wind up in the morgue. And there is nothing that my son or our family has been able in the past or can in the future do about it. It was a very disheartening experience that we did not want to make, to basically abandon her. We avoided that decision as long as we could, but eventually my son and us had to choose between supporting his wife or caring for his daughter to prevent her from having to be taken into DCF custody and placed in foster care. So what are the takeaways I'd like to leave with you from my family's experience? First off, professional mental health care for her has been very, very challenging. No one has ever been able to peel the onion back far enough to determine what exactly happened. What was the traumatic experience, which would help in being able to get her on the road to recovery. She has always been a very difficult patient, often stopping or refusing to take her medication, participate in therapy, or participate in peer support groups, or do the things that successfully recovered people have done. On Monday, as part of the panelists for Advocacy Day, we heard several presenters who talked about how they had done those things, and by doing those things, they had been able to move themselves into recovery and live very, very happy lives. She's never been able to do that. These behaviors have made her very difficult to deal with, and she has frequently resorted to substance abuse to take care of her problem. At one point, DCF actually reported to us that they had never ever seen a UA with so many illegal substances in it. She provided a UA that basically had every illegal substance that they test for showed up in that one UA. So as a result of the above, the community mental health services, namely NCSS, are really have been unequipped to care for her, as hard as they have tried, and they have put in hundreds of hours of effort, but they have been unequipped to care for her. The resources to care for her inpatient, beds, money, personnel, all of it, are really insufficient. She's been inpatient several times, but other times when she should have been taken inpatient, there was no bed. There were no resources available for her. Having her dumped back on our family's lap, which what happened up until the last couple of incidents, whenever she was released, she was just, okay, come back to the family. And she was sent back to us. That has taken an enormous financial, mental, emotional, and physical toll on my family. And in particular, she was typically released from inpatient with no clear understanding to us about what was done while she was inpatient or what the plan of follow-up treatment was supposed to be. So how were we supposed to help her? How were we supposed to deal with her when she came back out of inpatient? It was never clear. One very important thing that I think is absolutely vital, having mental health crisis workers embedded or available for police response is priceless. On numerous occasions, NCSS crisis workers assigned to the St. Albans Barracks of the Vermont State Police and responding with police officers were successful in de-escalating the situation and enabling the police officers to keep themselves safe and safely de-escalate the situation, keeping my family safe also. My family will forever be grateful for the professional, compassionate, and effectiveness with which the Vermont State Police Barracks have responded so many times to my family over this time period. Every police barracks in the state of Vermont, state police, local police, sheriff's office, needs to have mental health crisis support either embedded or on call to respond to mental health related crises. I have had many discussions I'm on a first name basis my family is on a first name basis with just about every police officer in the state police barracks in St. Albans. And we have talked to them several times, and every police officer in that barracks will uncategorically state the value to them and their ability to respond and support the community of having embedded mental health crisis workers. More work needs to be done on diagnosing and creating treatment for dual diagnosis patients. Our daughter was frequently told, well, she needs to go into substance abuse rehab, but her mental health related behaviors basically didn't make that possible. And I know some of the other respondents, some of the other participants on Monday talked about having dual diagnosis. And when you have a dual diagnosis, the treatment is very much more complex. And that's an area where I think we really are lacking. At the mental health advocacy panel, there were several success stories, people who have recovered from mental health issues. Unfortunately, my family story, at least at this moment, doesn't have a very happy ending. We keep being hopeful, but it's been very challenging for us. Yes, I guess I'm happy to answer any questions, but I guess as a final comment, I know it's been said that Vermont is rated number one in terms of mental health services, and I'm not saying that I would dispute that by any way, shape, or means, because the mental health people, there has been a lot of very positive work done. But if we're number one, I would hate to be a family in my situation and be in state that's number 50. It would be almost unbelievable. And even though we're number one, based on my family's experience, we definitely there's a lot that needs to be done to do better to serve people with mental health issues. So thank you very much for the opportunity to testify. I'd be glad to answer any questions if any of you have any questions that you want to ask.
John, thank you so much. That's a tragic story, very, very tragic. But the amazing work that you and your family have done to help, thank you for that. And what I think we may have lots of questions, but what I'd like to do is to move on to the folks who are here from the Howard Center and then have maybe open it up for a little discussion for some time. So we have
yes, that's fine.
Are you able to stay on?
Yes, ma'am. I can stay on for whatever we need. We can let Deanna speak.
Yeah, we'll spend a little more time. We're running into our schedule, but I think we're okay. We have time to do this. This is critically important.
I'm not sure if you noticed, but my granddaughter, she loves Zoom. And I think my wife and my other son, not her father, but my other son, I think they just took her outdoors for it because all of a sudden the sun's out. It's a beautiful day out.
Yeah, no, it just got beautiful.
She kind of peeked around the corner of my shoulder for a minute because you're lucky she didn't jump in front of the screen and give you all a wave. But
that's okay.
Okay, go ahead and let Deanna, and I'll be glad to stay.
Terrific, thank you. So, Deanna, welcome. And I didn't know if you and Margaret had planned how to provide testimony together. Is that what you're doing, or I'll let you just go ahead. Good.
Sure, thank you. And my heart goes out to you, John. As I hear your story, I want to thank you for sharing what you were able to share today. So many families I've talked to with unfortunate circumstances like yours. I wish I could say that your story was more unique and the anomaly, but I know so many people who have struggled in so many ways that it's so important to hear your words, and it's a hard act to follow. My goodness, it's so heartfelt. So thank you for your courage and your wisdom to bring this story today. I'm truly honored to speak to you all and provide testimony about the impact of the COVID-19 pandemic and Howard Center's mental health and crisis services. So I'm the crisis director with Howard Center and have worked in the field for close to 25 years. But the pandemic has ratcheted it up a notch in our community, as you all may anticipate. The initial news spread shock and disbelief among so many, but it didn't take us long in crisis to understand exactly how the reality of our crisis services would need to adapt and change as a result of this pandemic. We needed to continue to deliver safe and responsive services to our community and to those most vulnerable in our care. Seemingly overnight, Howard Center's 24/7 mobile crisis team, First Call for Chittenden County, Assessment and Triage Services launched telehealth screening, just overnight, new protocols to maintain services, and also reach those who did not have telehealth capability. Crisis residential programs responded with quick reflexes. We increased our sanitization procedures, procurement of necessary PPE. We implemented new COVID screening for residents and staff. We couldn't close our doors. We had to serve the people in our care. Outreach programs found themselves working in deserted streets. The merchants' offices, everything was closed. And the true community members, the homeless in our community, were left with no one to panhandle to help them. Social service agencies, stores were closed. So our outreach teams worked tirelessly, really, to relocate those homeless individuals into housing and get them food, delivering thousands of meals to them in the hotels. This was all in the very first few months of the pandemic. Now, at the cusp of only almost 1 year later, if you can believe it, we've changed the landscape of crisis. We've worked tirelessly to meet the demand in our community. We've reiterated policy, procedure, technology, infrastructure, and it's really a blur at this point of how we ended up doing this day after day. As essential workers, it wasn't a question of if we would continue to deliver services. It was just how. How do we do it? How do we reach everyone, regardless of those individuals who didn't have a phone, didn't have a way to communicate with us via telehealth, who were posing a risk and a danger to themselves or someone else, and really struggling with the pandemic. I'm tremendously grateful to all of our staff, our direct service staff, as well as our leaders who stepped up in every way to meet this need, and without whom many more in our community may have suffered very, very much so. We've learned so much in this past year. Among those lessons, we've realized the impact of loneliness, separation from loved ones, what that does to a person, and what happens when the community natural supports that provide really the backbone of our support system falter. We've seen many more deaths, more substance use, more overdose, more anxiety, and unfortunately, more suicide. If it wasn't for our essential workers and the ability to think outside the box, we merged whole programs from one building to another to collapse our staffing to keep services open. We launched telehealth, medical clearance for social detox, alcohol detox with the UVM Medical Center. We ramped up cross-training 24/7 and pulled people from other programs that were closed to support our residential services that could not close. We might have seen many more deaths if we hadn't done these things. Crisis programs remain open 24/7, 365 days a week. Round the clock, we offer outreach, support, triage, assessment, safety planning, and we partner with first responders, what John was talking about with our first responders. We partner with them and we try to achieve equilibrium. One of our clients referred to us as the beacon of light in these moments of need. We want to let families and individuals struggling with the community during this pandemic know they are not alone and we will get through it together. So that's my message. I hope to provide hope to those struggling in our community. We are all in this together and we're here for you. We do remain under-resourced, but I would like to turn it over to Maggie, who's joined me. She is one of our crisis clinicians, and I've asked her to share a little bit of what it's like to be on that front line of our essential workforce. Maggie?
Thanks, Deanna. I'm Maggie, and I've been a crisis clinician for 2 years here in Chittenden County. And then prior to that, I was working on tragedy response in Los Angeles, and I'm honored to be here. So working as a crisis clinician with First Call, I feel really lucky to work on a wonderful team of clinicians who are really accustomed to being flexible and creative through high stress situations, but have to say that COVID-19 definitely added a new layer to that, as we were facing a challenging and unfamiliar time alongside our community. As Dr. Ryerson mentioned, as a 24/7 team, sorry, our beagle's gonna alert you that the mailman's here. As a 24/7 team, we had to transition seemingly overnight. We moved our high energy call center to our home offices. We learned quickly how to assess high risk situations via Zoom and phone calls when we've been accustomed to working alongside clients face to face. And as frontline workers, we had to adjust PPE to the new PPE guidelines and share tips and tricks every single shift to try to keep up with the safety of our team and with our clients when we were doing in-person assessments. So I can definitely say that last March, we were prepared for an increase in crisis calls, and instead it felt really silent, like folks were in shock or waiting for this to pass. Then as the months went on, we started not only getting calls that we were used to from folks struggling with thoughts of suicide, with violence or psychosis, we also started getting new calls. We started hearing from high schoolers who were processing what it would be like to miss their prom or their graduation. We started hearing from parents who had lost their job and were waiting on unemployment while trying to be the best parent and teacher and friend and coach to their kids. And we started hearing from folks who had relapsed after years of sobriety and were encountering closed doors at support programs that were so crucial to them in these moments. We have heard from adults trying to weigh difficult decisions like whether to risk exposing an aging parent to COVID or letting them continue to feel isolated. It's just felt like everyone has been experiencing this compounded grief during loss after loss after loss with our team. And we've heard from people that are in pain and trying to foster hope during this immensely challenging time. And that's exactly what our team has worked to try to do. We listen, we connect community members of all ages to local resources, and we work with loved ones to boost support systems. We really aim to help people foster resilience and a sense of hope, even during this really challenging time. I feel really lucky to work a job where I hear life stories and am able to support folks through some of the darkest times in their lives. And although we get calls and complete crisis assessments all day, every single day, there's some that definitely stick with us. And one assessment this year that really stands out to me was a teenage girl who had already been through more trauma than many adults will ever face and continued to lack stability in her home environment. Her school counselor had found her journal with a suicide note in it and called our team. And when confronted about this note, the high schooler broke down, sharing that she didn't know who to talk to, but that she was feeling more alone than ever after being separated from her friends at school due to COVID-19. She shared that her friends were her support system, but since limiting school days and class sizes and even hugs with friends, she was feeling completely isolated. She told me that she couldn't picture her future anymore. She couldn't see herself going to college, finding a career, or falling in love. She just could not imagine that actually happening. And sitting in her counselor's office, we were able to create a space for her to process the feelings she'd been keeping carefully inside for months. We were able to work with her family and her school to build support, to answer questions around mental health and suicidal thoughts for that support system, and to develop a plan to get her intensive treatment for the next few weeks and then build support at home and open communication lines with her guardians moving forward. We were able to help her start to see a future again and recognize that the supports all around her were there for her and that many people really did care about her. And she's just one example of people that we are interacting with on a daily basis. So here we are, almost a full year after things first started shutting down, and I feel like we're continuing to adjust to the world changing around us. Our crisis team has always been busy, but when 2020 challenged us with a global pandemic, heightened political and racial tensions and an increased sense of hopelessness and isolation, we've really had no option other than to come together and learn and grow through it all. And I just want to echo what's been said, that if you or someone that you know is struggling to cope with the seemingly never-ending changes in this world, we really hope that you reach out to our team or your local crisis team, and we're continuing to push forward through all of this. So thank you so much for having me.
Oh, thank you both for your for what you presented to us. It's extremely helpful. If you do have something in writing, that would be good, because you highlight some of the mobile unit, the crisis team, so some of those things that are important to us as we going forward. And I've written down some ideas that maybe we can help. And I have been in touch with Bob Bick about some of his concerns, and I think you know Bob Bick, so we'll keep working on that. But I did want to ask one question, and then unfortunately our time is, we have to move on. But I did want to ask a question about John's story, and how do you work with someone like his daughter-in-law? I mean, obviously, fortunately, his grandchild has an excellent support system. But now she's out on her own, and substance use disorder, mental health needs. How do you, is there any continuity for someone like that? Is there a case management system in place to keep her attached?
I'm guessing you're directing the
yeah,
question
you can
to
all
me.
answer.
This is I'm sure everyone has thoughts. I think John was really right on when he talked about dual diagnosis being more complex. And our systems often speak in silos. Mental health is over here, substance use is over here, and they don't consider that almost, I would say the overwhelming majority of our clients and community are suffering from a combination of mental health and substance use misuse. And so when we have these fractured systems, it doesn't work well. So the best treatment is to provide treatment that is considering both angles, that's talking about the mental health, the trauma, as well as the substance use and relapse prevention, and that addresses some of those underlying factors that are also contributing to it. Ongoing treatment, engagement, hearing what might have been most helpful from the client perspective, and really meeting someone where they're at in their process of change. I don't expect that inpatient, if it had been extended for 2 or 3 more days, would have been the panacea in his situation. It would have needed ongoing, multi-level interventions way before you get to the point of needing police intervention and inpatient services. So the earlier we can intervene, we can screen and engage somebody when they are sober or when they're in that moment. And it takes multiple interventions to build that engagement, to make a relationship strong enough so that when someone is vulnerable and they're at their point of that crossroads, when they are thinking, do I go back to substances to manage this? Or do I, how do I manage those terrifying nightmares? Or how do I feel less anxious in my body? They need someone there to be able to talk to. And that can be at 2 o'clock in the morning or any time. And so really 24-hour support and engagement are outreach programs that are building relationships with individuals and seeing them time and time again to build those relationships and help them engage in services, I think is one strategy that might have been useful.
So yes, thank you for that. And John, you probably want to add just a comment, and then I think we're going to have to move on.
Oh, okay, hopefully, yeah, if I can have just a second. Yes.
Absolutely.
We recognize that one of the things that has been most disheartening for us is that we have been, there have been so many times when we felt, okay, we have her on the road. She's connecting with NCSS. She's doing, and it lasts, and all of a sudden she just, and she gives it up and she drives off the road almost, literally. And it's like we haven't known what really the mental health system or anybody could do to keep her on the road when she appears to make the conscious decision to, I'm not going to stay on the road, I'm going to drive off the road. And that is what has been most disheartening for us, is that no matter how many times we felt, okay, we've got her started, we're on the road and we're working the right path and we're doing these things, and then all of a sudden she just and veers off the road. And that has made it, I'm sure that the people at NCSS, there are probably several people at NCSS that have aged years trying to deal with it. And the Howard Center here in St. Albans, have it's yes, and it leaves us at a loss for how do you deal with someone who just flat refuses to do the things that we all know, as Deanna and Margaret have testified to. When you do the right things, you can get into recovery and you can get yourself under control and get your life back. And we've never been able to do that with her and get her to stay on the road. And
you've worked very hard as a family to help, and that's very clear. And thank you for your work, and thank you both Maggie and Deanna for your work. We know that recovery is multiple regression time. It takes time. Driving off the road, as you said, can happen many times before you finally find the straight and narrow. It's just difficult.
And one of the things that concerned us, and maybe Deanna or Margaret can say, one of the things that has concerned us is that a little bit like, injury from headbanging in football or soccer or whatever, there's every time you do it, there's just like a little bit of damage that doesn't get repaired. And our concern is that every time as she continued to go into psychotic and more deeper psychotic episodes, that each one of those episodes created a little bit of damage in the connections up there that were never going to get repaired. And one of our concerns is that at this point she has done so much damage because she's had so many psychotic episodes that's one of the things that we're facing, is that there has been a significant amount of irreparable damage done in her ability to even eventually, get into recovery. And I'd just be interested if Deanna or Margaret might have a comment about that.
Yeah, sure. Just take a minute and because that's a very important question. Deanna, did you want to answer that? Okay, go ahead.
I mean, we do know that the more significant episodes that someone experiences, the worse their prognosis over time. That's why I really anticipate that the best treatment is to get upstream, try to recognize early warning signs, stay engaged, follow those paths, excuse me, and make those connections and relationships so that maybe you can build insight and you can help, again, collaboratively develop a way to be ahead of it. It's not to say, though, that there's no hope. I think there's several people who have gone through significant episodes and recovered. And, in crisis, we unfortunately see people at their worst. But I'm lucky enough to know and see the value of peer support, where people are recovering, and despite significant trauma, significant episodes, they are on the other side of it. So I would say never give up hope. Continue to engage your daughter-in-law or ex-daughter-in-law in support and hearing stories of hope and recovery, so that they can visualize themselves on the other side and have that continued motivation to improve. They have to see it for themselves in order to make it happen.
Thank you. And thank you all for being here. Best luck and wishes to you, John, with your
Thank you.
daughter-in-law, and Deanna and Maggie. Thank you for the good work that you're doing, and please continue.
Thank you.
Yes. Take care. All right. Terrific.
Thank you.
So Jen Carby is here, and we are going to, it's difficult to transition from something as powerful and compelling as that, but we need to do that. So we're going to move on to, take care, John. We're going to move on to the flexibility bill. And do you have something for us to look at, Jen?
I do, and I believe Nellie has posted it. She has. I don't know if you want me to put it up or if you want to just look on your own devices or
put it up. Committee, we have notes from, and you put notes in, you said, Jen.
I did put a few notes in, yes.
All right, so if you see something that Jen missed, which she doesn't usually miss anything.
Well, it certainly happens. Let me, whoops. Well, I thought I put it.
Why don't we just go right through?
Okay. Trying to find. Well, I thought I had it, and then that's the one I want. Now, how do I get it to? Let me share that. There we go. All right. Okay. Can you see it now?
Oh, and it's highlighted.
Well, yes, that piece is highlighted and everything else highlighted in yellow where I put things in. This is just a reminder really to me to revisit the statement of purpose. Since it's a committee bill, I write the statement of purpose sort of as we go, and I want to make sure at the end it includes everything that's in it. So that's all. So this is, so the first part, as we had looked at before, is all of the Act 91 as amended by Act 140 provisions. So they all still say during a declared state of emergency in Vermont as a result of COVID-19 and for a period of 3 months following the termination of the state of emergency. So depending on what you decide, I will change those dates accordingly. And I don't know, do you want me to just move to the new, to what's new?
Yeah, let's go to the new first, and then we'll come back. And we have some time tomorrow also to go through the bill. And we'll also be hearing from our insurance people tomorrow. So that'll be
right.
Okay.
Okay. So I'll jump. So no changes for a while. We had walked through this the other day. So here's the first piece. This was the extension of prescriptions for maintenance medication that we had put in here and extended for that 3 months after the end of the state of emergency. OPR says this extension is not necessary. The authority was codified in the 2020 OPR bill, which had a number of provisions on pharmacists prescribing under their clinical pharmacy provisions. So I didn't want to take anything out without you having an opportunity to discuss or ask questions, but I wanted to at least flag it here.
Why don't we stop right here? Committee, is there any, based on the testimony we heard from OPR, is there any reason to leave it in? Does anybody want to leave it in? Senator Hooker?
No, not that I want to leave it in. I just want to know whether or not the what is in this bill, what was in the flexibility for this particular situation is now codified. Is it the same, Jen?
It's not written exactly the same. It serves the same purpose. The way the language was codified in the OPR bill, and I can actually pull up that statute and speak to you about it. So the statute that was amended last year in the OPR bill in the Professions and Occupations chapter or title in the pharmacy chapter had a number of provisions around what's been called clinical pharmacy. and it added some prescribing authority for pharmacists. And one of the things that it specifically includes, and I'll just search for it here, is that it allows a short-term extension. So there are sort of two avenues that pharmacists can use to be able to prescribe. There's a collaborative practice agreement that they would have with a prescriber, and then there's also a state protocol that the Commissioner of Health would adopt. In addition to those, so there may be ability to extend or just prescribe under those circumstances, but there's also short-term extensions, even in the absence of a collaborative practice agreement or state protocol. The pharmacist can prescribe up to a 5-day supply or the smallest available unit. They have to alert the prescriber that they have done this, and the short-term extension is only available on a one-time basis. So you had asked, I know, some questions, and I had flagged those for Lauren Hibbert before her testimony yesterday about the scope of that short-term or of the extension in this language. And, you know, is there any limit on how long, how many? So the statute does address that.
Okay, thank you.
Yes.
Any other questions on this? So I guess the question is just a show of hands. Shall we take this section out as suggested by OPR? Just if you think so, put your hand up. All right.
All right.
Yeah, good. One decision made.
Yes, and I'll check in with OPR, but my thought is not to delete the section from the Act 90, the underlying Act 91. So keep this provision sort of around through this June 30th, 2021 date, but not extend it beyond that. So we may have a little overlap for a while with what we currently do.
Yeah, that's a good point.
Okay.
Good point. Okay.
The next section is similar. This is the therapeutic substitution by pharmacists due to lack of availability. And again, what you heard from OPR was around this being codified in the 2020 OPR bill. So I have that language, and that says allows a practicing pharmacist to it allows a prescriber to authorize a pharmacist to substitute a drug with another one in the same therapeutic class if it would have substantially equivalent therapeutic effect, even though it's not a therapeutic equivalent drug. And there are some certain circumstances or certain parameters around that. So again, it's not exactly the same, but this provision would last through March 31st. And then they would still have the prescriber authorized substitution piece.
Okay, so that's similar to the last one we looked at.
Right. It serves the same or a very similar purpose. And so OPR had.
Yes, and I do remember hearing testimony on the OPR bill, and we did work on those provisions in our committee. So, questions on this one? Okay, so with a show of hands, would you like to take this out? If you do, raise your hand. If you want to keep it in, you won't. All right, so that's good. Does anyone want to leave it in? No. So we'll accept that recommendation from OPR. That goes.
Great. And then there was one other piece in here on OPR's part. That's right. And that was this temporary licensure provision says during a state of emergency, or, well, it would have extended it, currently runs through March 31st, that OPR can issue a temporary license to someone who's a graduate of an approved education program if the licensing exam required for their profession is not reasonably available. And this was actually codified in Act 91, so I'm a little confused about how we ended up putting it in Act 140, but OPR says it's not necessary.
Well, and when she was testifying yesterday, she said that the exams were available, but she also said that some of the availability was, like 6 months away. So, but I guess
Right, but they do have this authority anyway. So under existing statutes. So I
Right,
think
okay.
it sounded like some of the immediate need was perhaps less, but also that authority was codified.
Okay. All right, committee, questions of Jen? All right, with a show of hands, if you would like to drop this section from the bill, just raise your hand. All right. Anyone opposed to dropping it? No, we're good. All right.
Okay. So that's in section 2 of the bill. All right, great. And then we get to some new provisions. So the first is, this is the DFR emergency rulemaking piece. I didn't make any substantive changes to what we had looked at, but this was when I was doing the walkthrough the other day, I realized that it did not, I had failed to incorporate the changes from Act 159. So I pulled it out of that whole Act 91 rewrite because it had a separate, and it was amended another time. So this just includes, it's actually really in this earlier part where the language changes weren't reflected, and that's around some of the more specific authority regarding the COVID-19 diagnosis, treatment, and prevention.
And
again,
this still
I didn't make any
has the 3
substantive changes in this.
Yeah, this doesn't have a date certain yet. This has 3
Right.
months.
None of this
Okay.
has a date certain because you had not decided. It also has this ongoing, it does have a date certain for the audio only. And again, this is the piece that the House Committee is working on separately as well.
Okay.
Madam Chair, just a question for Jen. I'm confused as to your note on line 8, page 17. Says move to a new section and updated per Act 159. Are you talking about what is now section 3 or 15, depending on which sections you're looking at? Or are you talking about the next section, section 8?
So this is where it gets confusing because I'm amending session law. So it's section 4 of the bill is what I mean by, I don't know what's highlighting all that. Section 4 is what I mean by move to a new section. So I moved it to a new section of your bill to make the changes to it because the changes, because Act 159 only amended this one piece and not the rest of Act 91. So it's really section 8 of Act 91. That part, the fact that it is section 8 of Act 91 is the same. It's that I moved it to a new section of this bill for purposes of amending it.
Okay, I actually didn't.
Couldn't figure out the best way to say that, but
Yeah. And I didn't see the section 4. That's on line 6, right?
Yeah.
that's on line 6. It sort of blends in. That's why we at least try to indent so that you don't get section 4, section 8 all in a line. But it can be hard, definitely hard to find. And for whatever reason, I have found this one harder to identify, this section 4 in here as well.
And this is new in this draft. Like this wasn't included in your previous draft, or it was in a different section.
Exactly. It was embedded in that whole big Act 91 revisions earlier in the bill because I had neglected to include the Act 159 changes to the section. So I wanted to make sure that we were amending we should be amending the most recent version.
Okay, got it. Thank you.
Pulled it out, put it on its own, and showed the changes as current law. Sorry for the confusion.
Oh, wait.
More complicated than
Don't
intended.
be sorry for any
Okay.
confusion.
All right, so then we get to the 2 new pieces that we talked about earlier this morning. The first one is around advanced directives. And so as I mentioned, I had codified it. I put it into the statutes because it has long-term implications, even though the authority itself is time limited. And so I just put in here the 2 pieces that required date changes. So this was for the first set of circumstances was for advanced directives that had already happened. We don't need to extend that date because it was always backward looking. But the second set of witnessing provisions applies currently to advanced directives executed between June 15th, 2020 and June 30th, 2021. So I simply moved that date out a year to be June 15th, 2020 to June 30th, 2022. And then did the same thing in this language about the explainer, the person who has to explain the advance directive to the principal if the principal is being admitted to or is a resident of a nursing home or residential care facility, or is being admitted to or a patient in a hospital. There's that extra step for the explainer to explain the nature and effect of an advance directive. And again, this piece applies to the whole period, the backward looking and the forward looking, but because it still has that June 30th, 2021 piece in it, and move that out to 2022 as well.
Questions there for Jen? Okay.
So that's it on advanced directives. And then
Let me just ask this question. Are you comfortable with this committee? If, you know, does it feel, you can always come back with questions if you have them, but okay, yeah, it's good.
Okay.
All right.
And then the final piece is that immunization registry language. And I was able to follow up not only with Beth, but with David Englander from the health department. And because I realized that I wanted to do the language a little bit differently than what they had originally suggested. And we talked it through, and I think everyone is comfortable with it. So this would allow the department here being the Department of Health, to provide confidential registry information to healthcare provider networks serving Vermont patients. So that would also include things like providers in New Hampshire, Massachusetts, or New York who serve Vermont patients. That's existing law. Then to the Vermont Health Information Exchange. So that is the statewide health information exchange that Vital operates under statutory designation and by contract. And then it keeps in this other language, existing language, that with the approval of the commissioner to researchers under certain circumstances.
Okay, that looks good. Committee questions for that one? Go ahead.
I do have a question about when are people apprised of the fact that their information, their vaccination and immunization information is going to be shared, especially for those people who have opted out of having their information shared? I mean, does that happen at the time of the inoculation, or?
It's a good question. I'm not sure that I can answer that just because it's not within my scope of knowledge.
If they opted out from sharing, then I don't know how that happens. That's a question I think.
Well, their information does still go into the health information exchange. It's just not accessible to providers.
That's right.
So I don't know that there is, I mean, well, I'm looking at the immunization registry statute. So the immunization statute requires providers to report to the health department all data on immunizations within a certain period of time. And it allows the department to use the data to create this immunization registry information. So it is confidential and privileged, except as provided in this subsection we're looking at and another already in statute. Registry information about a particular adult would be provided upon request to that person, their healthcare provider, and their health insurer. Additional information can be provided to school nurses. Just looking to see if there is anything in here. So let's see.
So the Department of Health is requirements for reporting immunizations and adverse reactions to the Department of Health is different from access to individual patient records that might exist, say in VHI.
Right. So I don't believe that there is either an opportunity to opt out of having your information shared with the health department, or an opportunity to opt out of having health department registry data, or your information included in the registry. I think it all gets reported. The question, if you have opted out of having your information available to your providers through the health information exchange, then they likely would not be able to access this information either.
Okay,
At
so
least
that
not through the Vital portal.
so that would have been on part of the patient, the consumer, to have opted out, and that would be known.
Well, the opting out happens at the Vermont Health Information Exchange level.
It's at the provider level, and we went through, Senator Cummings will remember this, we went through significant discussion on opt-in, opt-out, and then how that would happen in the doctor's office or with whoever the provider is. And the patient, I think, still can fill out a form that says, I don't want to be in. Go ahead, Senator Cummings.
I talked to my primary care provider. Because I had no idea. No one had ever asked me if I wanted to opt in or opt out. I don't know. She didn't know either. She referred me to the person that does, admissions and the bookkeeping. And her suggestion was that we find a really simple way, because they've got so much paperwork for anyone in that office to sit down and explain, what this all means. She said it probably will slip through the cracks. So I don't know. I mean, have we done any follow-up to this?
Well, we can do that, but I would, yes, we can do that. And we have had Vital in for a long conversation about this. This provision here is not really about that. This provision
that I
here
understand.
is about a requirement that providers must report vaccinations to the Department of Health.
That's right. That requirement already exists.
Right. And then it is allowing for that information to go out onto the information exchange, so that for any patient for which they're continue to be opted in, any of those patients' records can be accessed appropriately, by physicians and other practitioners.
By their treating providers.
But this doesn't have to do with the underlying conditions of opt-in and opt-out. And as you know, that might be something that we can ask about another day. But
I understand that, but I think if that is something to put on our radar.
And I certainly appreciate the need for complete information on the immunizations.
Yeah, no, I'm happy to, we'll put that on our agenda at some point. Maybe not right away. Senator Hardy had a question.
Yeah, I mean, I was just going to say before this, that this is limited to just immunizations. It's not any other health care service that we're talking about, right, Jen? Just immunizations at this point with this provision.
This piece has to do specifically with the health department's immunization registry information.
Right.
That's it. So there's a lot of information already in the health information exchange, but part of the reason I wanted to put the section heading on this instead of just putting in subsection D is you can't tell what it's about otherwise.
Right, exactly. So I think that's very helpful, and we shouldn't get to confuse the two, because patients can still opt out of having their records shared more broadly, but this information would still be shared. And my recollection from when my kids get immunized is you sign a thing saying, yes, I agree to them getting their, immunization, and I understand that it will be shared with the Department of Health or something like that. It's sort of like it's already embedded in there. And then this would just share it with the information exchange. But, we might want to get an expert to come in and clarify it just to be sure, but
what would you like clarified?
That,
Okay, we
that,
can do that. What,
that this is just that exactly that this is just immunizations, because we just got into a broader conversation, and so it
so I take Jen's word on this and David Englander's. No, it is just immunizations. The reason we got into the broader conversation is Vermont Health Information Exchange is a large repository of patient data that goes beyond immunization. But this is only to allow for immunizations to go from the Department of Health to the patient data network, so the Vermont Health Information Exchange. So it doesn't affect what else is out in there. It doesn't affect how patients access what's out there, or the providers access what's out there. So that's we don't want to, and we will, based on Senator Cummings' interest and your interest, we'll try to look at the vital issue again, but not right away.
Well, I was only bringing it up because the conversation got broader, and I understand that it's narrow, but then it got confusing because it was broader. I absolutely trust what Jen is telling us, and I think we just got testimony that this was narrow, but because there was some confusion right now, I just wanted it to be doubly confirmed.
We're good. All right. Okay. So at this time, how are people feeling about this section for inclusion in the bill? And if you think it should be included in the bill, just raise your hand and say, and if you don't, we'll get another vote. So how do you do? All right. Now, anyone not wanted here? All right. Then I don't know how we confirm it beyond what we currently have done, but maybe we can get a double confirmation from David Englander on this from Department of Health. Anyway.
And then that's it. You know, I still think it makes sense for it to take effect on passage unless the committee has other thoughts. But because you are extending dates that start as early as, or potentially as early as March 31st, it seems like on passage is appropriate.
Okay. All right, good. So what's our time like? 7 minutes. All right. So tomorrow, I think, look through the notes that you have from the other day when we heard testimony. And we'll take further testimony from the insurance folks tomorrow. But then I guess the question really is the date certain and what perhaps a date certain should be, because it sounds like that's much more reassuring to everyone to have that date. The advanced directives has one now, and whether we extend everything to that point is now that's what we'll have to decide. So for tomorrow, I think we heard things like March 2022 from different folks. So think about the date that you think works, and based on the recommendations that we've heard from the people who have testified. And the March 22 date, I think, came from the large coalition. So it's pretty broad. I mean, it covers a number of people. And then we'll hear from the insurance people, and we'll continue to work on the bill. So, and we're also going to take some time. Jen, is there anything else that you need from us at this point in terms of getting anything back?
No, I don't think so. I mean, I can take out the pieces that we talked about taking out, and
and
then once you make a decision on the dates, I'll put those in.
Okay, perfect. All right, so then tomorrow we're also going to go back and circle back and look at S42, the wellness bill. And again, I was, as we all were, extremely moved by the testimony we heard from Chris Flores. And so I will probably be having a communication with him on behalf of the committee. We'll work on that. Is there anything else, committee, at this point? So I'm still a little bit confused about what we need more to confirm the immunization registry language, if anything.
I'm fine with it. I was
Okay.
confused by Senator Cummings bringing up the other issue, and I just wanted to make sure that for anybody who may be listening, that they understood that there was a broader issue, but this was a narrow issue. And yeah, that was my only point. Sometimes when we get sort of into tangential issues, then it gets confusing.
Thank you. That's very good.
One thing leads to another, but I wonder if there's a way. I know Jen put the heading on about immunizations. Is there any way to refer to immunizations within the language of the section?
Well, it does in the broader
does.
section. I can put more of the unamended language in. If you know, I mean, I can put the full text of the section in, or I can put in
Maybe
subsection A.
Yeah,
and then
maybe
we'll
add a little bit, just add a little bit. That might be reassuring.
Clarify.
Yes, I can do that. And Senator Lyons, I just looked through my file and my notes, and you did also have a communication from Devin Green about another section that they wanted to put in.
Right.
Or wanted to maybe look at making changes to, which is, I think, a provision that doesn't,
Right.
that is currently tied not to a date certain, that they're thinking might make sense to go with a date certain. So I can
you put that in for us
I
for
can
tomorrow?
put that-
And then
yes,
we'll,
I
we'll
can-
go right to that.
okay.
We'll take some time.
And
on
just
that.
for the rest of the committee, this is the language in the underlying bill that requires DVA to relax the provider enrollment provisions and DFR to direct the health insurers to relax their provider credentialing requirements so that providers could move between settings more easily. And that, I think, is currently tied to the last to terminate of the state declaration of emergency, the federal public health emergency, and the federal national emergency. So they're suggesting maybe a date certain that aligns with some of the licensing pieces would make more sense.
Okay, so we'll look at that tomorrow too. Thank you for reminding me.
Sure.
Okay, anything else? We're still early. That's good. So I'll see you tomorrow morning, bright and early, 9 o'clock. And we'll continue our work on these two bills. And I think then we'll talk about what's coming up next week. So we'll do that. All right. Take care. See you in a bit.